Mary, Mary Cooper here.
Hi, Mary.
Beth Boone here.
Hi, Beth.
I'm just making sure that everyone can see the screen while we are waiting.
Yes, Dr. Pasnoor, we can see the screen.
Thank you. Good, Kathy. How are you?
Doing fine.
Good. I think we have Laura, Nora. Nora, are you there? I'm just trying to see if you're there.
Yeah, I'm here. I'm
Okay.
recording.
Oh, you're recording already?
Yeah.
Yes. Oh, we don't start off. We wait for a few more minutes, right? Just making sure.
Yeah, we can wait, I think like 2 more minutes maybe, and then we can get started. And then if they need
Okay.
to cut off the beginning of the recording, I'm sure that they can.
Oh, okay. Okay. Well, and Nora, can you tell me if you're seeing this screen being advanced or not when I start did the screen advance or?
No, it's still, I can see the slides on the left if you didn't change it.
Okay, well, I mean, so it didn't advance. So let me just stop share and then go back and share it in a different way so that
Okay.
we can get it shared in a different view. I think sometimes it gives us a little bit of a problem with that view. That's good that we started a little early. Okay, let me restart. Okay, now I should be able to advance
Yes, it's full screen now.
full screen now. Okay.
Yes.
All right. I mean, whenever we are ready, I'm okay with starting off. Should I go ahead and start off, you think? Because we're already
Yeah, I think we have 51 participants in the room, so I think that should be good.
okay. I don't know how many registered, but okay. Well, welcome all. I'm Mamatha Pasnoor. I'm a neuromuscular physician at KU, and just like Dr. Dimachki, I've been his colleague, and I see patients with with the the muscle diseases, including autoimmune muscle diseases as well as neuromuscular junction disease, nerve diseases, and myositis, various types of myositis, as we discussed, including dermatomyositis. And some of you may have been in my clinic, and I know on this group. But so we'll go ahead and start off. I'll be talking mainly on dermatomyositis and anti-synthetase syndrome. And here are my disclosures. I do serve as a consultant and medical advisor on some of the pharmaceutical companies that make drugs related to this too. But I would not be using any of those in my talk here today. As far as just going over. What is inflammatory myopathies? First is diagnosing inflammatory myopathies, and then you distinguish the various types of inflammatory myopathies. So it's a rare disease that involves muscle inflammation. This includes muscle weakness and sometimes muscle pain. And the criteria that has been established many years ago, that in 1975, this was the very first criteria established for inflammatory myopathies, which was Bohan and Peter, by Bohan and Peter diagnostic criteria. This was symmetric proximal weakness over a few weeks to months, is what they said, creatine kinase elevation, and then muscle biopsy findings, EMG findings, and based on this, the diagnosis was made whether the patient has polymyositis, or if they had rash, it indicates dermatomyositis. At that time, they were not recognizing IBM or other conditions, but they said like if it is a slowly progressive course, that excludes the patients in this. So this did not include IBM at that time, and they did not include any of the antibodies into this criteria at that time. So since then, there have been various other criteria that came up. However, in that, with that Bohan and Peter criteria, I mean, the muscle biopsy, if you look at the biopsy findings, the polymyositis, they basically were describing this inflammatory muscle, inflammation around the muscle fibers and invading the normal muscle fibers. That's what you're looking for in the muscle fibers. So you see the muscle fibers here, and these are all the inflammatory cells that normally would help attack other, antigens that come into your body. Then now they're attacking your own muscle cells, and so that's why your muscle deteriorates. So this was the other criteria established later on by American College of Rheumatology and European League of Rheumatism Against Rheumatism and IAM scoring system based on whether they had a biopsy or they did not have a biopsy previously. There was various scores that were given into this, which was based on the age, the muscle weakness, and you can see skin manifestations of rash, Gottron's papules, Gottron's skin changes like Gottron's sign, or if they had dysphagia or esophageal dysmotility, or if they had so they included antibodies into this, and we'll talk about different types of antibodies, but this is just showing that anti-Jo1 antibody, and they also included CK levels and AST/ALT, that's the liver function test, and muscle biopsy findings into that. And based on this, we could now categorize them into definite, probable, or possible, instead of and give based on the scores that they happen. And this is commonly used even in the research studies right now. And the other, this based on this EULAR ACR 2017 classification, now we have that if the at age of onset is less than 18, then they can, if you say if they have if they're less than 18, then you're thinking of either juvenile myositis or juvenile dermatomyositis based on whether they have the rash or not. But if they are greater than 18, if they are more than 18 years old, then you have these various categories. If they have a rash, then you're calling it as either dermatomyositis or amyopathic dermatomyositis. I'm sorry, for some reason my slides keep going faster than me there. And then if they have no rash, then you're thinking of polymyositis. But now we have more than one in the polymyositis. We also have immune necrotizing myopathy included in this category. And then we have IBM included in this category based on whether they have certain muscle biopsy features or not, like vacuoles or other clinical features of IBM. You're looking at finger flexor weakness and knee extensor weakness. Those based on that, you're categorizing. So these are the main categories of the inflammatory myopathies that have been. And once you make that diagnosis, so this is the classification changes over the years. You can see initially in 1887, we were only diagnosing everyone with polymyositis. Then we started recognizing dermatomyositis and polymyositis. Now, later on, the inclusion body myositis was identified, and that was included into the inflammatory myopathies. And then following that, we started later on recognizing immune-mediated necrotizing myopathy. So some of the people who were diagnosed with polymyositis previously are now diagnosed with the immune-mediated necrotizing myopathy, which is, I mean, most commonly we see that with statins, but also seen in patients who are not on statins, but other immune. And we have been identifying more and more of these antibodies. So things have changed, and anti-synthetase syndrome was also classified as both dermatomyositis or polymyositis. And we'll talk a little more on the anti-synthetase syndrome. A new classification now is, to reduce all this confusion, a new classification has been is proposed. This is myositis-specific antibodies. and myositis-associated antibodies. These help define the subgroups of patients in terms of like their clinical, the pathological features, and what the prognosis is going to be, and how the response to treatment is going to be. And also, some of them can also be associated with increased risk of cancer, or some of them may be associated with more like clinical features of skin changes and rather than muscle weakness. So based on these antibodies, you can identify some of the clinical features that you may see in that. So what are the muscle specific antibodies? That is, these are specific to the inflammatory myopathies. So these are usually only one is seen in a patient. And if they have anti-amino acyl tRNA synthetases, HMGCR, SRP, MI2, MDA5, TIF1, and NXP2, and SAE. These are all muscle-specific antibodies. What are muscle-associated antibodies? So these are antibodies detected in patients with connective tissue disease, like overlapping myositis. They are found in multiple combinations and accompany the muscle specific. I mean, they may sometimes be accompany the muscle specific antibodies. So these can be anti-Rho, anti-La, like, these are all like you see in connective tissue diseases or rheumatologic diseases. So if they have those, these can be associated with some of the inflammatory myopathies. So just to give you an idea, and this will be using this diagram more as presented in Ben Veneste and in an current opinion of neurology in 2016. And this is a very nice picture to show you like where each one is. Like immune-mediated necrotizing myopathy has these antibodies that you can identify. Dermatomyositis, you can see all of these antibodies are identified, and we'll be talking a little more about that in the next few slides. Overlap myositis, you can see it there. This is inclusion body myositis. You have these antibodies, anti-CN1A, and these are newer, which were identified. And here is the anti-synthetase syndrome antibodies associated with that. And you can see there are quite a few antibodies that are associated with those, which Jo1 being the common one that we all recognize more often because it's been known for a longer time. So going on to dermatomyositis, coming to our topic, it's an inflammatory myopathy, just like we discussed earlier, with associated with rash and weakness. And people can have rash and weakness, but then there is a clinically amyopathic dermatomyositis where people can have rash without a significant weakness. In this, they have divided this into two categories. One is hypomyopathic dermatomyositis or amyopathic dermatomyositis. Hypomyopathic is when they lack clinical weakness. However, when you do a lab test or EMG test or muscle biopsy, you may find some changes in them that suggest muscle involvement. Whereas amyopathic, all of this will be negative. You don't see any muscle involvement, but just the skin involvement. That is amyopathic dermatomyositis. So the treatment may be slightly different in some of these, that's why we are even trying to differentiate them. So just the epidemiology, incidence is about 1.1 per 100,000 person years, and approximately about 2,800, close to 3,000 new cases each year. And prevalence is about 13 per 100,000 per year, persons per year, approximately about 34,000 individuals in US. Still a rare disease, and you can see the prevalence can be varied in different countries, more prevalent in some countries compared to others. Age groups affected is usually around 40 to 60s. And children, again, you can see a child, juvenile onset also. And it affects more females than males. Why is that? Again, we see more autoimmune conditions affecting female patients more than the male patients for some reason. And as far as the acute subacute and chronic presentation. You can see the clinical features. They can present acutely or subacute or chronic, like over a few weeks to months, and they have progressive weakness, progressive changes in the skin, and you can see here Gottron's papules, like thickened skin lesions at the knuckles, and heliotrope rash around the face, shawl sign, that is, the changes around the neck and around the in the anterior and posterior part of the neck where it's exposed to the sun, and joint contractures can be seen. In children, we sometimes see calcinosis, that is calcium deposits, and vasculitis, which is inflammation of the blood vessels. You can see malignancy in some of them, and these are some of the changes we see. I know sometimes we talk about the mechanics hands. We'll talk about that more in the other conditions, but that's the skin lesions in the palms. You can sometimes see that. And diagnostic tests, usually CPK is maybe normal, but can be elevated. Normal in about 10% of the patients, does not correlate with the severity of weakness. Biomarker panel may show various dermatomyositis specific antibodies, and EMG may show irritative myopathy, and muscle biopsy findings may be seen in this, which is, we'll talk about those findings. ENMC 2018 classification criteria. Again, this is the criteria that has been used based on the clinical examination, the skin findings, or you can have proximal weakness, elevated muscle enzymes with associated with these antibodies. We talked about those, some of the antibodies here that I mentioned here, anti-TIF1, NXP2, MI2, MDA5, SAE, and you can see there are some features that you should recognize, like some people with anti-synthetase syndrome may have a dermatomyositis like rash. So when you see these patients, it's basically, it can be the classified as having anti-synthetase syndrome with dermatomyositis. I'm sorry, anyone has a question? Or let's see. All right, maybe it was okay, we'll continue. And if there's a question, we'll definitely answer it after this presentation. And anti-HMGCR myopathy with dermatomyositis rash can be seen if they have anti-HMGCR antibodies and a rash. Anti-SRP myopathy with dermatomyositis like rash has been seen in anti-SRP patients, and autoantibody negative dermatomyositis may be seen in some patients with dermatomyositis specific, when there is no antibody, like, so there are various subcategorizations. And then some patients may have, some people with dermatomyositis may have ulcerating lesions instead of like Gottron's papules. So there are other skin changes that sometimes may be seen in, especially in MDA5 associated patients with, the MDA5 antibody. So let's go on to the next slide. And, based on, which antibody they have, people can have different findings, like they may have more muscle weakness in anti-MI2. If you look at more skin changes in TIF1, anti-NXP2, they may CK levels may be very high. And in MI2, it may be high. MDA5, more associated with the interstitial lung disease. Like I said earlier, if you know which antibody they have, we look for more of these findings on either on the skin or on the, if you look at the cancer risk, if someone has anti-TIF1 gamma, then the cancer risk is high. So you're looking more for cancer in this group of people who have anti-TIF1 gamma. So based on which antibody is positive, we look for more. So if you have anti-MI2 antibody, the cancer risk may be lower than compared to the others. Even anti-MDA5, the cancer risk may be lower, but the interstitial lung disease may be higher. So based on which antibody you have, the risk may be different. Perivascular atrophy, again, the muscle biopsy, this is the classic finding, perivascular atrophy. What do we mean by that? When you look at the the muscle biopsy, these are all your muscle fibers. You can see that the muscle fibers along the line here, along the connective tissue here, is much smaller. They look smaller. That is the atrophy. That is they're shrinking in the area, in that area, compared to the ones in the middle of this fascicle. We call each of this a fascicle. And you see that these are smaller here. You can see that they are smaller there. Why are they smaller? Why are they atrophied? There is some changes of the muscles along the edge, and we think maybe it's because of the inflammation causing that damage to those muscle fibers. Deposition of so there's deposition of, and you can see all these inflammatory cells, all these dark cells there, macrophages eating up the muscle and around the blood vessels. You can see that deposition of immunoglobulin and complement. These are endomysial capillaries and small blood vessels. We need to know about this, that the complement system they are, and the membrane attack complexes, because this will help us, develop medications and target them. Electron microscopy shows some tubular reticular inclusions. So these are changes that you see on muscle biopsy. So cancer screening, what is the recommendation on cancer screening? This is, I think Dr. Warren will be talking a little more about all of this, but basically definition within 3 to 4 years, typically 1.5 year from onset for TIF1 gamma, and CT of the chest abdomen, and like for male, do the prostate screening. For female, ultrasound mammography in women, ultrasound of testis in men, colonoscopy in men and women over 50. So these, you need all the primary screening as well as repeat screening is recommended 3 to 6 months. Thereafter, every 6 months up to 4 years is what they're recommending now. There wasn't a clear guidance in the past, but now I think, we have more guidance on this. Increased risk of cancer, like I said, I mean, there have been studies. This systematic review looked at, what is the risk of cancer, what makes cancer more of a risk if they are older age, if you have dysphagia, like is difficulty swallowing, or if you have an anti-TIF1 gamma positivity, then you have an increased risk of, and if what is reduced risk is when you have anti-Jo1 or very high serum CK or Raynaud's phenomenon associated, and polymyositis subtype, or if you have clinically amyopathic dermatomyositis. Like I said, if they have skin lesion but no significant weakness, then they have reduced risk of cancer. I mean, this was the association they have seen in the systematic review. So some things to remember when we think of cancer in patients with dermatomyositis. And CT scanning of the thorax, abdomen, and pelvis appeared to be effective in identifying some of this. So these are the medications just to go over. Is first line is prednisone, IV methylprednisolone, methotrexate, azathioprine. Second line, commonly used azathioprine, methotrexate, but IVIG, there's a randomized control trial. Azathioprine, there's been a control trial. So these, you can see wherever we put in a star, they were randomized control trials. Some of them positive, and so IVIG, that's how it was approved for the treatment. Mycophenolate, I mean Sulsat, we don't have a randomized control trial. So most of them we don't have to control trials, particularly in dermatomyositis. However, have been used in other autoimmune conditions, and therefore we use them. Acthar there was a control trial. There was a trial which was completed again recently, and there is again the other, you can see chlorambucil and other trials here. We'll go on with some of the JAK inhibitors. This is exciting, like area that has been looked at for treatment of dermatomyositis. The JAK inhibitors, tofacitinib was studied in 10 treatment refractory patients, and they showed basically improvement prior to the start, washout steroid sparing effect. The washout of steroid sparing agents, was done. So they washed them out of other agents and then looked at improvement, and they did notice 5 of 10 minimal improvement, and moderate improvement was in 5 out of 10. So the CDASI score also improved, and basically mean CK at baseline was 82, and disease activity was predominantly skin, and there was marked this did show some improvement but this was an open label study, and so they recommended that doing more randomized control trials would be better. The same, looking at this was a systematic review looking at, all the all the case reports on patients who were treated with dermatomyositis and with JAK inhibitors, these medications that work on this mechanism. And there were a total of 84 patients that they had looked at in all of these reports. These were not randomized control trials, unfortunately, but the refractory, I mean, they saw that refractory skin disease, 61 patients all reported improvement after the JAK treatment, the JAK inhibitor treatment. Refractory muscle disease was also improved in 16, all of them improved. Interstitial lung disease was in 31 patients, and all of, again, they showed improvement in with these treatments. And conclusions were that these inhibitors may be a viable treatment option. However, you have to remember these were in different studies and not all in the same study, all patients in the same study. And this was like more of a case reports and a case series rather than like a randomized control trials. Randomized control trials are necessary to confirm these is what they ended up with. And IVIG, like I said, this was the trial that led to the approval of dermatomyositis, and this was Dr. Agarwal and colleagues had, and this led to the July 2021 US FDA approval for adult dermatomyositis. And so this is 2 gram per kilogram of body weight of placebo every 4 weeks for 16 weeks is what they have done. And they had an extension phase for 24 weeks in this. So basically, going on to anti-synthetase syndrome, like I said, here you can see this is the anti-synthetase syndrome, which is part of the overlap myositis. And you can see these are the antibodies. If they have these antibodies, we are talking about anti-synthetase syndrome. So what is anti-synthetase syndrome? So one is it's an inflammatory myopathy, sometimes called anti-Jo1 syndrome. It's an autoimmune condition just like the others. Autoantibodies to amino acid RNA synthetases, and symptoms and clinical features vary from person to person, and they can have polyarthralgia, Raynaud's phenomenon, mechanics hands, unexplained fevers, and interstitial lung disease. The most common, like I highlighted in red there, are myositis, polyarthralgia, interstitial lung disease. This was a patient with interstitial lung disease where you can see all the lung changes. Normally it should be like this. You're seeing all of that changes in the lungs. And you can see anti-synthetase antibodies, like I mentioned, these are all the antibodies that are associated with the autoantigen that is associated with that. And as you can see, anti-Jo1 is the most common, but severe lung disease is seen in anti-PL7, and if they have anti-PL12, they have severe interstitial lung disease. So these two are associated with severe interstitial lung disease, whereas Jo1 is the most common anti-synthetase syndrome. So there have been diagnostic criteria proposed by various people, Connors et al. In 2010, Solomon et al. In 2011, and the presence of, for both of them, the presence of amino acid RNA synthetase antibody is important. So one of those antibodies should be present, and then one of the major of clinical criteria is they mentioned in this criteria, whereas in this they said at least 2 major or 1 major and 2 minor criteria. So what are the others, like interstitial lung disease, the polymyositis or dermatomyositis by Bohan criteria, arthritis, Raynaud's phenomenon, mechanics hands. So you can see mechanics hands has been included in the criteria here for so anti-synthetase syndrome. So the patients usually are in teens to adults, mean age is around 50s. Again, females more common than males, just like other autoimmune conditions, and differs depending on anti-synthetase antibody present. Like I mentioned earlier, like muscle disease is more common in some. If you have anti-Jo1, EJ, PL7, if you have anti-PL2, you may have more clinically diagnosed amyopathic dermatomyositis or interstitial lung disease alone without muscle disease. And anti-KS, this interstitial lung disease may be more common. Jo1 and PL7 prevalence of muscle symptoms was significantly lower in patients with anti-PL7 and PL12. Like I said, lung was more common than that. So, and biomarker panel. So how you diagnose with all of these? The biomarker panel is what we all order after we see people in the, I mean, when we see a patient who comes in with weakness, we usually order all these tests. Like, so we look at CK, we order the biomarker panel, which includes all these antibodies. And and based on that, we do a high resolution CT, lung biopsy if necessary, if you're thinking of interstitial lung disease, muscle biopsy. Dr. Hamblin will be talking this afternoon more on lung findings, muscle biopsy, like I said, all those muscle changes, and then treatment depends on what you're seeing. If you'll need a team of physicians to work with you, like a pulmonologist, a rheumatologist, a neurologist, and as you all already are familiar with, you're referred to multiple physicians. We all work together. Corticosteroids is usually the first line, even with this condition, and steroid-sparing agents, again, azathioprine, mycophenolate, tacrolimus, rituximab, and cyclophosphamide. And you'll be hearing from Nora later on some of the clinical trials that are ongoing here at KU and also in other places. I didn't include all of the studies that are presently in Kansas as well as in others. This morning, I was trying to look at the clinicaltrials.gov. There were quite a few studies that were listed, but again, not specifically for anti-synthetase syndrome, but just for inflammatory myopathies in general. So I'll stop it there and then allow people to ask any questions. I think we have a few minutes, at least close to 10 minutes, I think there. So I'll just allow anyone who has questions to go ahead, and I'll see if I have any in the chat right now to begin with.
I have a question.
Yes, go ahead, Robert.
I was treated initially about 5 or 6 years ago with Rituxan and favorably. And then by happenstance, I took a fall and without getting into the details, was diagnosed with lung cancer. The question was it the interstitial lung disease, which came first, the chicken or the egg? Anyway, I'm completely free and clear of lung cancer, and I dodged the COVID bullet for about 4 or 5 years. This past March, I came down with COVID and I did I'm retired from the medical field, some reading, and there seems to be an association of COVID and dermatomyositis. Do you have any new information in that area? Because right now, I'm back to, I spent 8 or 9 weeks in a hospital this summer for another reason, adjusting medications. Never was really sick, but without physical therapy. And it's taken its toll. I was in pretty good shape up until this COVID experience. Can you shed some light on what the newest research is on COVID and dermatomyositis?
Yeah, so I mean, that's a great question. I mean, so autoimmune diseases, it's hard to say like if it would really be associated with COVID infection or COVID, the COVID vaccination. Again, some uh, people did get worse sometimes with infections like autoimmune diseases sometimes can be worse again because someone if someone is on immune suppressive medications, there is a high risk of infections and, more risk of getting infections. But COVID was so common, it's hard to particularly say if that would be the etiology of causing dermatomyositis. Is that the question that you were asking, like whether COVID is actually causing worsening of the dermatomyositis?
Yes, there seem to be some early papers. The science is obviously very early, but there seemed to be an association with a few of these papers of the new COVID, and this was the most recent COVID. My only symptom was fatigue, but the new COVID and existing dermatomyositis.
Um, yeah, so I don't know if there were like any particular studies looking at that, if that would actually worsen. But I think most of those were like case reports, but I don't think there's any like real study to say if I know there has been like MDA5 with dermatomyositis maybe has I mean, like some of these, if COVID-19 and, causing a systemic inflammatory response, may be causing it worsening of the lung disease, but I don't think there's exactly like a clear study, not that I know of. I mean, again, I have to say, I don't think I know specific study that looked at worsening in this in this group.
I can send you the link if you give your email.
Yeah,
I'll send
definitely.
you.
Is that the mini review you're talking about?
I'm sorry.
Is that the mini review in PMC by J. Kwan?
I'd have to go back and look, to be honest with
Yeah, I know there's a Frontiers Immunology 2022 article that COVID-19 can induce a systemic inflammatory response, is what they had mentioned.
you. Okay, I'll be happy to send that to you. And
Sure.
what is your email?
mpasnoor@kumc.edu. Because I think that article basically looked at exploring the possibility of the relationship, but I don't think,
No,
they.
it was not
uh,
a definitive study, but
yeah, exactly.
okay. All right. Well, thank you so much for that.
Sure.
And
Sure. I mean, I know there's like the Chinese, I think, is the Frontiers of Neurology. They had one on that.
so right now, my path to getting back to where I was, uh, I think I'm paying the price for virtually in two very good hospitals with almost no physical therapy, shortage of staff, and so on. So I'm working very hard as an outpatient to get back to where I was. And it's a slow road back, but I'm getting there.
Yeah, and like I mentioned, sometimes when you are on immunosuppressive therapies, the infections because you're at risk of infections, the it takes a longer time to heal back, when you get these infections, and they may appear to be more severe. The infections may be more severe for you.
Okay.
That might take a little longer because you're immune suppressed.
Well,
Uh,
I have an upcoming visit with my rheumatologist who is a Johns Hopkins guy, and it's very smart. But by the same token, I think I have to present, biomarker panels and muscle biopsies as making a more complete diagnosis of where I am right now.
Yeah,
Because what he normally does is do the creatine levels.
yeah. I mean, in dermatomyositis, creatine levels may not always give us all the answers. So I think it's important that we do that, check the biomarker panel. Helps us. I think
Thank,
this, thank
thank you.
you.
I hope this helps some of the other people that are
Yeah,
in the
I see
room.
some in the chat. What's the difference between prevalence and incidence? I think prevalence is like, how much it's when you just look at all the number of cases in the community, and whereas incidence is like how many new cases that you're seeing in the instance. So
All things considered, I think I was one of the fortunate ones in terms of my success with the initial Rituxan. It was
that's
very effective, and then unfortunately the cancer, but I'm cancer free.
yeah,
Treated with uh, chemo, and so
sure.
I've been cancer free with routine CT scans for the last 2 or 3 years now.
Yeah. Well, I'm glad that it's taken care of. And yeah, thank you, Robert, for this question.
Thank you.
Sure.
We're about to wrap up the breakout rooms, Dr. Pasnoor. So just letting you know, maybe time for one more question.
Okay. Uh, And I think someone asked about JAK inhibitor and mycophenolate. That's a great question. Tacrolimus and prednisone all at the same time. Again, we try not to put on multiple therapies if possible. Most of if you look at the trial for JAK, they try to take patients off of other immunosuppressive therapies before you put on them. They all work different. However, we again, there has to be more studies to say how the interaction would be, or, with more immunosuppression, more risk of infections. So, I mean, in some people, you may have to use more than one, based on how severe how severe their symptoms are. However, we try to reduce to, a prednisone and one immunosuppressive therapy if possible. I hope that answers that question. What does remission look like? I think one more question answer, and then we'll stop it there. Remission is, again, it would be nice to be off of medication and not have symptoms, or in some people, you may have some baseline deficits which are not worsening, and trying to get you off of medications. That would be what I would consider as remission. And I think if Nora, are we out of time, or
I think we can do one more question.
one more question? What is known about people with long-standing anti-Jo1 positivity, but who don't have sufficient symptoms warranting treatment yet? Is this a common situation or rare in the anti-Jo1 population? How often should they be monitored for the change? That's a good question. I mean, if you have just the antibody positive and no symptoms, they can be just monitored once a year. And you can be followed by your primary physician, and if any symptoms appear, like if you have symptoms like weakness or rash or any other symptoms, then can be like, difficulty breathing or any of those symptoms, then can be followed with your physician. If you're having just the antibody and nothing, no other symptoms, you don't need to be, I mean, you don't have to do anything further if everything has been done at the initial diagnosis. Like, the first time you diagnose someone, we see the antibodies, we do all the testing to make sure you don't have, like I mentioned, some people in dermatomyositis may have amyopathic dermatomyositis or hypomyopathic, where you need to make sure they do not have any other biopsy findings or other findings, lab findings, before we say, they do not have. So, I mean, if you have been having the antibody and did not have any symptoms for a long time, would say just wait and just yearly once with your primary physician or with the neuromuscular specialist would be fine. And what is the first line treatment of anti-synthetase syndrome for people unable to tolerate steroid therapy? And that's a good question. I think, again, people have used azathioprine as well as methotrexate based on, it depends on what you have, whether it is a lung involvement or the polyarthritis, like a polyarthralgia. So based on what involvement is more, your treatment might be slightly different. So that's what I would say for that. And I have minor weakness in proximal muscles, but more weakness in the distal muscles. Can you explain that? Again, not examining you, it's hard for me to specifically say that, but usually with dermatomyositis, it's more proximal weakness. Again, IBM has a different phenotype altogether. If you're having some distal weakness, usually, and if it's more than the proximal weakness, maybe looking into other conditions is important before we say it's all due to dermatomyositis or polymyositis or any of these conditions. So making sure there's no other cause for that distal weakness. When we say distal weakness, are we talking about foot drop or foot weakness, or is it in the hand? So based on that, it could be different diagnosis. So I think again, it should be like some muscle dystrophies affect more distal than proximal, again, thinking of those. So there is various other conditions that also should be looked into if there is more distal weakness than proximal weakness. Especially in this, like myotonic dystrophy sometimes can cause distal weakness. And, so there are other conditions that can cause more distal weakness. And then I see Gian asked if we are supposed to taper off prednisone before starting methotrexate, but there is a lengthy gap before methotrexate kicks in. How do we handle that pain? That is a good question. Pain, again, the treatment may not always be just the immunosuppressive therapies. There are other treatments for pain, but usually the prednisone taper is slow taper while we are giving methotrexate at the same time. So I'm not sure methotrexate, how your taper was, but usually the taper is slow taper of prednisone along with the gradual increase of methotrexate to get to the level of where it's stable. And in the meanwhile, if it is pain, they can probably treat pain with the different medications to help with the pain. How long can one stay on hydroxychloroquine? That is a good question. I don't use hydroxychloroquine as much as rheumatologists. We do have one of our rheumatologists on this afternoon. Maybe that's a question to ask them because I know rheumatologists use hydroxychloroquine more than us neurologists. We don't use it as much, but it usually depends on how, what your side effects are. Like, people start developing, eye symptoms, and that's something which they monitor closely and change based on I did see patients on hydroxychloroquine for many years. So I don't think it is a major issue if you're on it for a long time. However, monitoring the side effects is important. Dermatomyositis diagnosis, EMG and muscle biopsy negative, TIF1 positive, no real weakness, but awful muscle pain. Is that from dermatomyositis or something else? I'm on Cellcept, Imiran, and Plaquenil. If it is just pain you're treating, may not, I mean, if your muscle biopsy was negative, EMG was negative, I mean, TIF1 is positive, again, don't just treat the antibody, we always say you have to treat a person as a whole and not just an antibody. Sometimes antibodies can be false positive, but in this case, because it's TIF1, again, that can be associated with cancers. Checking for cancer routinely is important, and I'm sure your doctor might be following that closely. That is important to look into. And Nora, let me know when I'm supposed to stop.
Yeah,
I
you're okay. I'm waiting to hear from Ali, so I'll let you know whenever to stop. But I think you're good to keep going. I think everyone's kind of behind in their room, so you're good.
Is that right? Okay.
Yeah.
I'm just, going down the list of,
Yeah.
if anyone has any questions that needs to be answered, if you want to unmute also is fine. I know we are just, I'm just going through the list of questions that were asked here. Let me
Hi,
see what's.
sorry to interrupt you. My name's Nishanta. I just had a quick question I wondered if you could kindly answer. I'm in the UK, so things maybe work slightly differently. I'm under a rheumatologist, and have a diagnosis of lupus and inflammatory arthritis. I'm 40, so fairly young in the world of, of getting all those diagnoses. I had a blood test done about 2 weeks ago, and my rheumatologist basically mentioned that I was MDA5 positive,
Uh-huh, uh-huh.
which is really strange because from the beginning of my lupus diagnosis, I had extreme weakness in my hands, and no one really paid attention to it. They just kind of ignored the symptoms. So kind of all this is linking in, which is quite scary. I kind of said, what does this mean? And he obviously said myositis. That's what it means, possible lung involvement, and then kind of said, but you'll be fine. Um, so I haven't really had any backup support. So it's been quite scary having that diagnosis and then the rheumatologist saying kind of go away with it, you'll be fine. I'm on obviously hydrochloroquine and methotrexate,
Uh-huh.
which I'm getting on really well with. So I just kind of wondered the diagnosis or the blood test alone of the MDA5, is that kind of a solid, would that be considered solid for a diagnosis? Because I haven't been offered any other, you mentioned biopsies and things like that. I don't know if they do that in the UK. But I just wondered if that alone would stand as, with symptoms, because, I was in a flare up last week, and the first thing I noticed was actually weakness in my legs and my arms, which was a really
Yeah.
strange. I thought, oh my gosh, this is new.
Yeah, so again,
Yeah.
I think if you look at the dermatomyositis classification, it's not
Yeah.
just the antibodies, but usually you want to see clinical signs and examination findings,
Okay.
like Gordon's papules, Gordon's features, these are some of the things that we're looking at, skin biopsy, skin findings of those clinical findings, as well as, if there are no clinical findings, then like muscle biopsies might help with that, so like I mentioned, in some people, just MDA5, that's good that you have. I mean, like that, we know that there is an antibody, which is nice to know that. But in addition to that, do you have a clear evidence of dermatomyositis or not? I think it would be nice to establish that. So, I mean, is like the thing is like, are they making the diagnosis? It sounds like you're already on the treatment,
Yeah.
so that's the thing. I mean, like maybe because of that, they want to just treat it as, you're being treated.
Yeah.
So, because you're already on the medication for that, for the treatment. So, maybe, and sometimes if you're on a medication and if you do a biopsy, you may not see all the findings. That is also an issue, So, that might be one of the reasons why they are treating as they are treating. Sometimes if you have to, like, I mean, if you're not responding to the treatment, then they may want to do, like, they usually do further testing and make sure that, or if you're progressing despite being on the treatment, then they do further testing and see, like, try to confirm that diagnosis. That's probably what we would do if we are doubtful about the diagnosis, or if you're not responding to the treatment. But if you're already being treated, they might
Yeah.
just follow clinically, I'm thinking.
Oh,
So,
thank you. Thank you for your advice. That's really kind.
sure, no problem. I'm glad that you're on here and be able to hear all the details on some of these conditions. And
Yes, wonderful. Thank you so much.
sure. I think going on through these online questions there from the chat, can MSA antibodies occur with other autoimmune condition? Muscle-specific antibodies, these are specific for inflammatory conditions. If you're talking about muscle-associated antibodies, those are associated with other autoimmune conditions. So I don't know if you're asking that, or if there is, if I answered that or not. Uh, because I mean, if it's MSA, like muscle-specific antibodies, it's an inflammatory, they are usually associated with inflammatory myopathies. Is the overlap syndrome considered the same as having a myositis disease like dermatomyositis along with lupus, or is it different altogether? So that goes back to our diagram. The dermatomyositis is different from the overlap syndrome. So these are different conditions, although the treatment may not be a whole lot different. The prognosis and might be different, and even if you look at the clinical situation, might be different in both these conditions, because some of them may be associated with